Welcome to the second part of Section 5. In this part of Section 5, I will be going through specific examples of acid-base disorders. Let's jump right into the questions. How would the pH, PCO2, bicarb, and urinary pH change in a patient with a 2-year history of asthma? Asthma causes restriction of the airways, which decreases the ability of the lungs to remove carbon dioxide from the circulation. So in this case, PCO2 increases. And as you'll recall from the previous lecture, results in a right shift, which means carbon dioxide gets converted into acid, which can be remembered by using the reaction from the previous lecture. Carbon dioxide and water react to form carbonic acid, which then gets converted into bicarb and acid. So again, carbon dioxide gets converted into acid. The increased acid lowers the pH, and after a period of 24 to 48 hours, the kidneys attempt to compensate for the primary acid-base disturbance. Let's draw out one of the pictures from the previous lecture to help illustrate this. This is the proximal convoluted tubule of the nephron. This is the lumen, and this is the interstitium. Within the cells of the proximal convoluted tubule, carbon dioxide and water react to form bicarbonate and hydrogen. The bicarbonate is reabsorbed, and acid is secreted into the lumen through the sodium-hydrogen antiporter. The filtered bicarbonate reacts with the hydrogen ions that are secreted to form carbon dioxide and water. The carbon dioxide and water diffuse into the cells of the proximal convoluted tubule, and the process starts over again. Recall that in a chronic respiratory acidosis, the free hydrogen in the blood gets transferred to the lumen of the nephron, and this ultimately increases the reabsorption of bicarbonate. So in this case, we'd expect the bicarbonate concentration to be elevated. Finally, during an acidosis, the kidneys compensate by increasing the excretion of acid in the form of ammonium and dihydrogen phosphate, which results in increased acid in the urine, so the urinary pH decreases. So again, the pH is low, the PCO2 is high, the bicarbonate is high, and the urinary pH is low. If we refer to the flowchart, we can see that a chronic respiratory acidosis would result in a right shift, and we'd expect a low pH and a high PCO2 and a high bicarbonate. Okay, here's another pearl. What drugs are commonly associated with an acute respiratory acidosis? Opioids. This shows up everywhere. Opioids like morphine and codeine are obvious, so these are less likely to show up on exams. In my opinion, heroin is the highest yield of the opioid drugs. These drugs act on many receptors and cause many changes throughout the body, but for our example, it's important to know that they cause respiratory depression, which is responsible for the acute respiratory acidosis. Okay, let's move on to another example. How would the pH, PCO2, bicarb, and the partial pressure of oxygen within the arterial system change in a patient who is climbing Mount Everest for the first time? Recall from the chapter on pulmonology that the atmospheric pressure decreases as altitude increases. From the equation PiO2 equals FiO2 times the atmospheric pressure minus the partial pressure of water, we can see that if the atmospheric pressure goes down, then the partial pressure of inspired oxygen also goes down. So again, PiO2 is the partial pressure of inspired oxygen. FiO2 is the fraction of inspired oxygen. Normally only 21% of the air is composed of oxygen. PATM is the atmospheric pressure, and pH2O is the partial pressure of water. Remember, the partial pressure of inspired oxygen, or PiO2, is a major contributor to the partial pressure of oxygen in the alveoli, or P big A O2. Recall that P big A O2 equals PiO2 minus P small a CO2 over R, where P big A O2 is the partial pressure of oxygen in the alveoli, PiO2 is the partial pressure of inspired air, P small a CO2 is the partial pressure of carbon dioxide in the arterial blood, and R is the respiratory quotient. So as you can see from this equation, the oxygen reaching the alveoli is decreased at high altitudes, which means the oxygen reaching the arterial blood also decreases. So as you can see, if the atmospheric pressure is decreased, which is what occurs at high altitudes, then the PiO2 is decreased. If the PiO2 is decreased, then the partial pressure of oxygen reaching the alveoli is also decreased. And then finally, if the partial pressure of oxygen in the alveoli is decreased, then we also know that that means that less oxygen is reaching the arterial blood. So the PaO2 is decreased. Recall from the chapter on cardiology that the peripheral chemoreceptors in the carotid and aortic bodies detect the decreased PaO2, which then send afferent signals to the medulla through cranial nerves 9 and 10. So let me draw that out. This is the aorta, and here's the carotid body, and there are chemoreceptors that send their signals to the medulla through cranial nerves 9 and 10. The medulla then sends efferent signals to the lungs, which results in hyperventilation. This makes sense. The body thinks it's starved for oxygen, so it begins to increase ventilation in an attempt to increase the oxygen in the blood. However, because the atmospheric pressure is low, the hyperventilation doesn't do much to improve the P small a O2. Instead, it increases the removal of carbon dioxide from the circulation, which induces a metabolic alkalosis. Recall from the reaction, carbon dioxide plus water reacts to form bicarb and acid, that a drop in CO2 will cause the equation to shift left, resulting in decreased free hydrogen ions. This will then cause a rise in the pH, or an alkalosis. If the patient had just begun the ascent, then the bicarb would be normal or slightly decreased, because the kidneys wouldn't have had time to compensate. However, after a day or so, the normal compensatory response in this case would be for the kidneys to decrease the reabsorption of bicarbonate. This makes sense. The decreased bicarbonate would allow the free hydrogen ion concentration to rise. So let's draw this picture out again. Again, this is the proximal convoluted tubule. This is the lumen of the nephron. This is the interstitium. Carbon dioxide and water react to form bicarbonate and acid. The bicarbonate is reabsorbed and the acid is secreted. The filtered bicarb reacts with the acid to form carbon dioxide and water, which then diffuse into the proximal convoluted tubule. We can see that a drop in free hydrogen ions in the lumen of the nephron will allow more bicarbonate to escape reabsorption. In other words, the bicarbonate excretion will increase, resulting in a low bicarbonate concentration in the blood. So in summary, a patient with acute altitude sickness would have a high pH, a low PCO2, a low bicarb, and a low PaO2. A patient with chronic altitude sickness would have similar numbers, but the pH would be slightly more normal due to the increased excretion of bicarbonate, which means the bicarbonate would be even lower. Here's another example. Let's say a middle-aged man with a history of depression has attempted suicide by ingesting a known substance. His pH is 7.2, PCO2 is 21, bicarb is 10, sodium is 140, and chloride is 100. So low pH, low PCO2, low bicarb, normal sodium, and normal chloride. The first step in tackling this problem is determining if the patient has an acidosis or an alkalosis. From the pH, we can see that he has an acidosis. Now we check the carbon dioxide and bicarb. The CO2 is low, so immediately you should be thinking he must have a metabolic acidosis, because CO2 would have to be high in a respiratory acidosis. A low bicarbonate confirms that the patient does have a metabolic acidosis. Now we've been given sodium bicarbon chloride, so we need to calculate an anion gap. Remember, anion gap is calculated by taking sodium and subtracting chloride and bicarb. In this case, 140 minus 100 plus 10, which equals 30. A normal anion gap is between 8 and 12, so this patient clearly has an anion gap metabolic acidosis. At this point, we should think about the Winters formula and determine if the lungs are adequately compensating. Recall that the Winters formula is PCO2 equals 1.5 times bicarb plus 8 plus or minus 2. In this case, we plug in bicarb, which would be 1.5 times 10, which equals 15, plus 8, which equals 23, plus or minus 2, which gives us a range of 21 to 25. So given this patient's bicarb, we'd expect the PCO2 to be between 21 and 25. This patient's PCO2 is 21, which is within our predicted range. So the lungs are compensating adequately. With this information, we can determine that the patient has an anion gap metabolic acidosis with adequate respiratory compensation. Finally, we need to think about the mnemonic mud piles and consider a diagnosis in conjunction with the patient's history. On a multiple choice test, the answer here would be obvious if you had gotten this far. From the mnemonic mud piles, you'd likely see methanol, propylene glycol, or ethylene glycol as one of the potential choices given this patient's history of attempted suicide by ingesting an unknown substance. If we refer to the flowchart, we can see that an anion gap metabolic acidosis would result in a left shift, and we'd expect a low pH, a low PCO2, and a low bicarbonate. Moving on to another example, let's say there is a 21-year-old female who presents to the emergency department. She's sweating profusely, she's tachycardic, and says her symptoms came on spontaneously several hours ago. Her pH is high, her PCO2 is low, and her bicarb is low normal. So what should be your diagnosis? Spontaneous tachycardia and diaphoresis in a young female is likely indicative of a panic attack. We know that her pH is high, so she has an alkalosis. We also know her PCO2 is low, so she's hyperventilating. Recall from our reaction that a drop in carbon dioxide will cause a left shift, resulting in decreased free hydrogen ions in the plasma and a subsequent rise in pH, or an alkalosis. Finally, an acute panic attack would likely result in normal or slightly low bicarbonate because renal compensation hasn't had time to adequately occur. If we refer to the flowchart, we can see that an acute respiratory alkalosis would result in a left shift, and we'd expect a high pH, a low PCO2, and a normal or slightly decreased bicarb. Okay, here's another question. How would the bicarbonate concentration be affected in a patient with lactic acidosis? Recall from the mnemonic mud piles that the L represents lactic acidosis, so we can deduce that this patient has an anion gap metabolic acidosis. Remember from the reaction that a metabolic acidosis results in decreased bicarbonate concentration. This makes sense. The lactic acid reacts with and consumes the bicarbonate buffer, which results in a left shift and hyperventilation. So in this case, we'd expect the bicarbonate concentration to be low. How would renal failure affect the pH of the serum? I'll draw this out to make things clear. This is the proximal convoluted tubule, this is the lumen of the nephron, and this is the interstitium. Within the cells of the proximal convoluted tubule, carbon dioxide and water react to form bicarbonate and hydrogen. The bicarbonate is normally reabsorbed, which helps buffer the pH of the serum. So in renal failure, the kidneys can't reabsorb bicarbonate as effectively, and the pH drops. Also recall that the kidneys secrete acid in the form of ammonium and dihydrogen phosphate, which should be reduced in a patient with renal failure. Finally, the alpha intercalated cells normally secrete acid, which would also be defective in this patient. So both of these effects would result in a decreased ability to secrete acid, which means more acid would be in the blood, which would lower the pH of the serum. Here's another example. Let's say an 8-year-old girl presents to the emergency department because she's hyperventilating. Her pH is 7.33, PCO2 is 24, bicarb is 19, sodium is 145, and chloride is 105. So low pH, low PCO2, low bicarb, normal sodium, and normal chloride. The first step in tackling this problem is determining if the patient has an acidosis or an alkalosis. From the pH, we can see that she has an acidosis. Now we check the PCO2 and the bicarb. The PCO2 is low. So immediately you should be thinking she must have a metabolic acidosis because carbon dioxide would have to be high in a respiratory acidosis. A low bicarbonate confirms that the patient does have a metabolic acidosis. Now we've been given sodium, bicarb, and chloride, so we need to calculate an anion gap. Remember, anion gap is calculated by taking sodium and subtracting chloride and bicarb. In this case, 145 minus 105 plus 19, or 21. A normal anion gap is between 8 and 12, so this patient clearly has an anion gap metabolic acidosis. At this point, we should think about the Winters formula and determine if the lungs are adequately compensating. Recall that the Winters formula is PCO2 equals 1.5 times bicarb plus 8 plus or minus 2. In this case, we'd plug the bicarb in, which would be 1.5 times 19, which equals 28.5, plus 8, which equals 36.5, plus or minus 2, which gives us a range of 34.5 to 38.5. The patient's PCO2 is 24, which is not within our predicted range, so the lungs aren't compensating adequately. Because the measured PCO2, 24, is less than the predicted PCO2, 34.5 to 38.5, this patient has a concomitant respiratory alkalosis. This makes sense. The patient is breathing way faster than necessary, which means excess carbon dioxide is being removed from the circulation, which causes a huge left shift and drastically reduces the acid in the blood, which means this patient has both a metabolic acidosis and a respiratory alkalosis. Again, because this is an anion gap metabolic acidosis, we need to think about mud piles. And we also need to think of reasons that could be contributing to a concomitant respiratory alkalosis. So perhaps methanol, propylene glycol, iron tablets, ethylene glycol, or salicylate ingestion could explain the anion gap. In this case, salicylate poisoning could be possible because it can cause a respiratory alkalosis and then transition to a metabolic acidosis. Okay, here's another question. How would acetazolamide affect the concentration of ammonium and dihydrogen phosphate in the lumen of the nephron? Let's draw this out. This is the proximal convoluted tubule. This is the lumen of the nephron, and this is the interstitium. Water and carbon dioxide react within the PCT to form bicarb and acid. Bicarb is reabsorbed, and the acid is secreted. As we know, the same reaction occurs in the lumen of the nephron. Recall that acetazolamide is a drug that works by inhibiting the enzyme carbonic anhydrase, which catalyzes this reaction. It's important to know that it inhibits both the luminal carbonic anhydrase and the intracellular carbonic anhydrase. So the intracellular acid cannot be formed, and the luminal bicarbonate cannot be reabsorbed. Because there is less intracellular acid formation, there is less acid in the lumen of the nephron. Recall that hydrogen phosphate is filtered and binds with hydrogen to form dihydrogen phosphate. Also recall that glutamine is used to synthesize ammonia, which is secreted into the lumen and then buffers acid to form ammonium. So you can see that in the presence of acetazolamide, the luminal hydrogen concentration decreases, which results in decreased concentrations of dihydrogen phosphate and ammonium within the lumen of the nephron. Because the bicarb can't be reabsorbed and the acid can't be secreted, acetazolamide induces a metabolic acidosis. Okay, here's another question. What would the pH, PCO2, bicarb, and anion gap be in a patient with severe diarrhea from a viral infection? Recall that diarrhea is the D in the mnemonic HARDAS, which is useful in remembering the causes of a non-anion gap metabolic acidosis. So with this in mind, we should be able to figure this out. Recall from our equation that patients with diarrhea lose excess bicarbonate through the stool, which results in an accumulation of free hydrogen ions in the blood. This then lowers the pH, which is responsible for the metabolic acidosis. So bicarb and pH should both be low. Also recall from this reaction that the lungs compensate for metabolic acidosis by hyperventilating. The loss of carbon dioxide causes a left shift and reduces the concentration of free acid in the blood, which helps mitigate the severity of the acidosis. So in this patient, we'd expect the pH to be low, the PCO2 to be low, the bicarb to be low, and the anion gap to be normal from our mnemonic HARDAS, which is used for a normal anion gap metabolic acidosis. Okay, moving on to our final example. This example is something similar to a clinical vignette you'd see in an NBME or UWorld. So a 52-year-old woman presents to the emergency department with decompensated congestive heart failure. After her condition is stabilized and her volume status is controlled with bumetanide, she's told to follow up with her primary care physician. After several weeks, she sees the primary care physician, who is now concerned about an acid-base abnormality. So what would the blood pH, urine chloride, and blood bicarbonate concentration likely be in this patient? Okay, so we know this patient was started on bumetanide. which is a loop diuretic. So this is the thick ascending limb, this is the lumen, and this is the interstitium. The NKCC channel absorbs sodium, potassium, and chloride. The basolateral side of the thick ascending limb has other channels that allow the reabsorption of these electrolytes into the blood. Recall that loop diuretics block the NKCC channel, which results in the loss of sodium, potassium, and chloride. This also results in water loss and hypovolemia, which then stimulates the renin-angiotensin-aldosterone system. As aldosterone increases the excretion of acid, the concentration of bicarb begins to accumulate in the blood, which causes a metabolic alkalosis. Initially, after starting the loop diuretic, much of the chloride would be lost in the urine, so the initial urine chloride would be high. However, because this patient has been on a loop diuretic for several weeks, the chloride concentration in the blood is likely low, which means there is less filtered chloride, and therefore less chloride lost in the urine. So in this patient, we'd expect to see a low urine chloride. So again, this patient would have a metabolic alkalosis with a high pH, a low urine chloride, and a high bicarbonate.